Hello, my name is Dr. Don Casey, and I'm bringing together four other co-authors from the Mayo Clinic Proceedings Quality and Outcomes study that we have recently published entitled What Constitutes Adequate Control of High Blood Pressure, Current Considerations. And I'm pleased to have three of our co-authors available for this, so we hope to provide you with a brief insight into this new article. First thing I want to emphasize is that the 2017 blood pressure guideline that people speak about is actually endorsed by 11 specialty societies. And so, again, without naming them, this often gets called the ACC AHA guideline, but in fact, we have 11 major endorsing organizations, and I put an additional list of some other organizations such as the American Diabetes Association and the Chronic Kidney Disease International Group to talk about the fact that this is becoming very important across the field of medicine. So one of the things we wish to highlight in our article is these crucial first steps for successful control, which includes correctly staging and classifying high blood pressure according to these 2017 guidelines. We're going to talk briefly about the critical importance of accurate measurement in accordance with the evidence-based process for accurate measurement for both healthcare and home settings, and then talk about the importance of including blood pressure control in a more comprehensive look around ASCVD or atherosclerotic cardiovascular disease risk reduction. So I'm going to introduce my first colleague, Dr. Jeff Williamson, who's going to talk about the guideline statements of this taxonomy as well as its critical importance in the evolving evidence of blood pressure control. Dr. Williamson.
Thank you, Don. As with many other fields, the field of hypertension continues to build on evidence, both epidemiologically and clinical trials data, to help the clinician and the patient understand a more practical guide to their own risk and how well they're doing as well. We see this in the same thing happening in many areas of healthcare and in society, where we have evolving guidelines on things like seatbelt usages or evolving guidelines on growth charts for pediatric populations. The same goes for hypertension. And you see the chart in front of you now, which is based on a wealth of evidence over the last 20 to 30 years showing these categories. And I think it's especially important to note that people above 130 have been shown to have a significantly higher risk of cardiovascular disease and also to benefit significantly from treatment. And then higher levels, of course, over 140, even greater risk. And of course, then over 180, that's an urgent situation. Finally, for the clinician, even 120 to 129 is something we need to talk to patients about. And so you can read the article and find more of the reasons why this chart should be handy for all clinicians.
Thanks, Jeff. Next is Dr. Daniel Pullman. Dan, talk to us about the critical importance of accurate measurement.
Yeah, thank you, Don. So this is kind of to me, one of the most important aspects of blood pressure management. I think it's sometimes underemphasized, the importance of accuracy during the hecticness of patient visits. And there are myriad of things that can cause false readings or non-accurate readings. And some of those are listed on this slide. It's important to note that both office and home blood pressure readings can be affected by these kinds of errors. So obviously this is broken down in this slide to some patient-related aspects, such as nicotine consumption or caffeine consumption, procedure-related, aspects, like the position of the body and the position and fitting of the cuff, so-called miscuffing. And also just sometimes errors of the user. So that could be the healthcare provider, or it may be an invalid machine. So it's very important to note that when we are checking blood pressure and striving for accuracy, we really need to pay attention to our technique, patient preparation, and proper utilization of validated equipment. And that could be at home or in the office.
Great. And I know that if Dr. Purcell, who's one of our co-authors, could have joined us, he would agree with all of us that if we don't start with the proper measurement, then we're off to the wrong start. So Dr. A.J. Blood, talk about why it's important to think more globally about blood pressure control in the context of overall atherosclerotic cardiovascular disease.
Thanks so much, Don. And as highlighted by my co-authors, really huge opportunities to improve the likelihood that a patient will never have to deal with atherosclerotic cardiovascular disease by improving both the accurate measurement and treatment of hypertension. We like to think about atherosclerotic cardiovascular disease far beyond just the heart, but again, the vascular system and microvasculature, where everything from the eyes to the kidneys is known to be affected by the time out of control. So really looking at this as opposed to just in the 15 minutes during a visit, thinking about the year that the patient is home, using that opportunity to check in on and measure blood pressure, oftentimes with some good data around team-based approaches to monitor and manage this over the long term has been shown to reduce the incidence and severity of cardiovascular disease. So really excited to broaden this scope and include many across the medicine discipline and reducing the morbidity and mortality associated with the uncontrolled hypertension that we see in the population. And I think just highlighting here in the next slide, thank you, Don, really looking at non-pharmacologic interventions. Of course, pharmacologic interventions are oftentimes necessary, appropriate, and clinically indicated for many of our patients. But I think the first first step for everyone should always be intervening in non-pharmacologic or incorporating non-pharmacologic treatments into our management of hypertension, both with physical activity, the foods that we eat and don't eat and recommend our patients to consume and not consume. So again, 90 to 150 minutes of regular physical exercise. Again, getting good, healthy diets, colorful plate, the Mediterranean, low salt, low potassium, where high potassium, where we can really optimize patients' cardiovascular risks by incorporating dietary and lifestyle modifications and encouraging those over the long term, in addition to pharmacologic therapy when appropriate.
Thanks, Dr. Blood. And so really our article is now moving from first steps into how do we actually make improvements in reducing cardiovascular risk. And really what we intend now to show is that a combination of assessing social drivers or determinants of health is a very important step given the amount of healthcare disparities that exist, especially for high blood pressure. But we also want to bring into play the fact that the decisions about patient-centered care must rely on shared decision-making. And that in order to do this and achieve effective modification of not just blood pressure, but other key ASCVD risk factors, we need to build trust and engagement with team-based care when available. And this is important too, because the 2019 prevention guidelines showed, for the most part, high quality to fairly high quality evidence around these three portions of the approach to care that we highlight under the name of the golden triangle in our article, and something that I think is really critically important. In the end, though, this is not going to be done by placing the responsibility back just in the primary care office. So this is a hierarchy starting at the top of what we call the blueprint for change, which includes, as we summarize, accurate measurement, looking at social drivers and determinants of health up front, assessing and reducing ASCVD risk through shared decision-making, and having a true evidence-based team approach to this, which is expectantly dependent on concomitant care delivery redesign. Digital health is obviously going to play a bigger role with the transmission of blood pressure readings. But where we want to end up is understanding that this is not, in my mind, in our minds, a major high priority at the health system level. And given that high blood pressure is perhaps the #1 health problem in the world, we need to move towards a more focus at the top of the organizations. We need to have standardized performance measures that we emphasize in our article. And lastly, end up with effective shared accountability, not just within health systems, but across all aspects of the health system. So we thank you for your attention, and we hope that you will keep in touch with us, and please let us know your thoughts for this new article. Thank you.